Good morning, everyone, and welcome to the Joint State Federal Relations and International Insurance Issues Committee. I am not Rachel Roberts, but I am Senator Jerry Klein from North Dakota. I'm the roving committee chairman, and so I'll be chairing this meeting today. I need a motion to waive the quorum requirement. Is there a motion? I have a motion over here. Is there a second? All in favor of the motion say aye. Opposed, no. Motion carried. Motion to approve the minutes of the November 18th meeting. A motion by Brian. Is there a second? Lana seconds it. All in favor of the motion say aye. Opposed, no. Motion carried. We have quite an agenda this morning and, well, actually into the afternoon. We're continuing with some new testimony that we introduced at our last meeting in November. And of course, anyone in the audience who is not scheduled to speak but has some concerns or a position on an issue can certainly find a slip, turn it in, give it to the speaker's table. And you can feel free to submit a slip on any issue. It doesn't necessarily have to be a model law or resolution. All right, we are going to start today with some brief remarks on an international issue titled Basel III Endgame. Is it disruptive to the U.S.? And with us today, we have got Kevin McKechnie of the American Bankers Association. The document has been distributed, I believe, to you and is on the website and the app as well that summarizes some of the ABA's concerns with that proposal. So we're going to hold questions till the end, and with that, Kevin, go ahead.
Thank you very much, Mr. Chairman. Good morning, members of the committee. Thank you for having me. A brief report. The topic today has been named, rather ironically, appropriately. Too much capital regulation means credit is at an end game, and I don't know if they meant to name it that way, but that's been the net effect. The federal banking regulators, Federal Reserve Board, Federal Deposit Insurance Corporation, Office of the Comptroller of the Currency, proposed last summer a broad capital rule that has so far drawn 3 congressional hearings, 2 in the Senate last November and December, 1 in the House Financial Services Committee just about a month ago. And in those hearings, the question under study, and you can see perhaps some of the bias in the name of the hearing, especially in the House, which is why are we importing international rules when we should be defending the sovereignty of the United States federal system. That has drawn some interesting criticism. What are they talking about? If you could, in your mind, think about the desk in front of you, and on that desk you had 10 dimes. If you took one of those dimes and moved it up, that would, roughly speaking, be the capital reserve strategy we currently employ. What's being proposed instead of that 1 dime is putting another dime forward and taking that capital out of circulation and holding it against risks that other commenters have said remain undefined, meaning the principal criticism of the Basel III proposal is there has been no robust study of the economy and the harms the proposal seeks to remedy. And until such time as there is, there likely will not be a lot of support for it. There's not a lot of political support for it now. In the wake of the Senate Banking Committee hearing in December, all Republican United States senators signed a letter to the Federal Reserve Board and the other banking agencies asking the question I just asked. Exactly what kind of harms is this proposal trying to solve? Well, it'll affect every bank over $100 billion, and that sounds big. It's not. The largest banks in the country, JP Morgan Chase, has 34 times more assets than that. The next largest bank, Bank of America, has 25 times more assets than that, which is to say that these new capital rules are going to affect the overwhelming majority of capital being held in financial institutions in this country. And what they mean by that is they're going to idle money. And money idled is money you can't use. What can't you use it for? It will affect mortgages. It will affect credit cards. It will affect car loans. It will affect consumer loans. It will mean that if you wanted to have bonds for new schools, for new sewer systems, for new capital projects in your states and localities, the cost of that credit is going to go up. How much up, we don't know. But if you take 2 dimes out of that 10-dime line, the worth of those other 8 dimes goes up. That's how economics works. It's been criticized rather extensively, and if you need to find a short-form way to explain it to others, I recommend the comments of Jamie Dimon in December. To paraphrase, in 2008, there was a financial crisis, and since then, the financial institutions of in this country are holding triple the common equity Tier 1 capital that they used to, 300% more. Well, how much is that? It's 7 times more capital than federal financial institutions need to accommodate the anticipated losses from the stress tests the Federal Reserve imposed. That's a lot of capital. And remember, that's capital that's not moving. And that's the definition of the problem. I promised I would keep this brief. This is not a simple subject, but that's the summary. And we're waiting to see if there's going to be a modification to the proposed regulation. And of course, this is an election year. And so one side of the political system has said they disagree profoundly with the regulation. The other side has not. Elections matter. We shall see. Happy to answer any questions you have, Mr. Chairman.
Any questions for Kevin? Any questions? I think I understand. We certainly are constantly bombarded by outside the country influence, and how my constituents would suggest, where are we going with this? And once again, are we having to answer that again? That it's being suggested that we have to go to this new ratio, by some of that out of state, out of country sort of dominance.
That's what's being suggested. This is an effort to harmonize capital standards across the globe, and we've seen this in other places. And you have meetings, Mr. Chairman, for the rest of this meeting on things like data. Data standards are trying to be harmonized across the globe. And climate, I'm not sure that word means anything anymore. No one seems to define it, but that's trying to be harmonized around the globe.
Any other questions? And I guess, Kevin, we'll be looking forward to continued reports as this thing continues to evolve and come forth. So appreciate your efforts and appreciate all your information. So
thank you for having me.
Next on the agenda, we have an overview of the new prior authorization rules from the Centers for Medicare and Medicaid Services. Joining us today, Randy, formerly with CMS, who will provide an overview of the rules and what we and our constituents should be aware of. So we're going to hold questions once again to the end, Randy, and just go ahead.
Sure. Thank you, Mr. Chairman. Really appreciate that. Again, my name is Randy Pate. I'm currently in private consulting practice. I'm also the president of StatesWork, which is an educational nonprofit that provides free technical assistance to states pursuing market-based health reforms. But more apropos for this meeting, I'm the former director of the Center for Consumer Information Insurance Oversight at CMS. I've served in that capacity in the previous administration. I just want to be clear, I did not draft the rules that we're going to be talking about today, and I'm not necessarily an advocate of them. I just want to provide background and answer any questions to the best of my ability. So HHS issued this final rule back in January. The rule applies across a wide range of payers and providers. It defines impacted providers as plans, issuers, and state programs who are subject to the earlier CMS interoperability and patient access rule. This includes Medicare Advantage organizations, state Medicaid and CHIP fee-for-service programs, Medicaid managed care programs, CHIP managed care programs, and qualified health plan issuers on the federally facilitated exchange. It does not include self-funded ERISA plans, large group fully insured plans, off-exchange individual market health plans, whether they're in federally facilitated exchange states or state-based exchanges states, qualified health plans in states with their own exchanges, or alternative plans like short-term limited duration. A major feature of the final rule is that the requirement There's a requirement for impacted payers to implement and maintain a series of application program interfaces, or APIs, aimed at improving and streamlining the exchange of certain health information as well as prior authorization processes. The final rule also includes provider incentives under MIPS to encourage adoption of the APIs. It contains certain other requirements related to prior authorization that I'll talk about that are applicable January 1st of 2026. However, the payer compliance with the API requirements I'm going to talk about was delayed until January 1st, 2027. HHS delayed this compliance date in response to feedback from the stakeholders and payers, where they expressed the need to have sufficient time to plan, develop, test, and implement the required API changes. They also cited feedback relating to the need to further standardize and mature the implementation guidelines for these APIs. So the final rule includes requirements for 4 APIs: the Patient Access API, Provider Access API, Payer-to-Payer API, and the Prior Authorization API. I'm going to briefly walk through these so you have an idea of what they include. For the Patient Access API, the rule requires impacted payers to include information on prior authorization. All of these APIs exclude any prior authorization data for prescription drugs, just want to make that clear. But the data under this API has to be available to patients, and it includes individual claims and encounter data, data classes and elements in the U.S. core data for interoperability data set, and specified prior authorization data. The prior authorization data includes the date the prior authorization request was approved or denied, circumstances under which prior authorization would end, items and services approved, the denial reason, if any, and provider clinical documentation if it was submitted. The information has to be made available to patients no later than 1 business day after receipt of the request and must be updated no later than 1 business day after any status change. And it has to be available for at least 1 year after the latest status change. The second API is called the Provider Access API. I'll just mention it. It's intended to facilitate care coordination and support the shift to value-based payment arrangements. It's not really focused on prior auth, so I'll just gloss over that one. And the same with the Payer-to-Payer API, which is the third one. It's intended to support continuity of care, and it has to include claims and encounter data, but is not relevant to prior authorization. And then finally, the fourth one is called the Prior Authorization API, and it will also go into effect on January 1st, 2027. It applies to all impacted payers. Under this API, payers must populate a list of covered items and services, as well as provide documentation of prior authorization requirements for those services. Payers have to include support for prior authorization requests and responses within that API, and they must, lost my page. They must also communicate whether the prior authorization request was approved or denied and the approval circumstances, denial reason, or duration. For all of these APIs, HHS says that it will exercise enforcement discretion on payer use of a certain prior authorization transaction standard as long as the payer does use this API. And then finally, the rule also includes some improvements to overall prior authorization processes. It requires payers to send prior authorization decisions within 72 hours for urgent or expedited requests, and within 7 calendar days for non-urgent or standard requests. It also requires a provider notice. All impacted payers must provide specific reason for denial, regardless of method used, to send the prior authorization request. So that includes fax, email, and so on. And it also finally includes some rules around collection and publication of prior authorization metrics. So the payers must start publicly reporting on their websites these metrics beginning in 2026. And with that, I will take any questions. Thank you.
Any questions for Randy? Any questions? We have, Senator.
Randy, thank you so much for being here. It's good to see you again. A question that I had is when this whole information on pre-authorization, where is that available? And you said that goes into effect in 2026?
Right, so the APIs, the sort of data interchange part is not really in effect until January of 2027. But these earlier changes will start, early 2026, so say March of 2026. You'll see the insurance companies having to start post metrics on, approvals and denials, for example, of prior authorization requests beginning at that time.
Thank you. Thank you, Mr. Chair.
All right, any other questions? Yes, Representative.
All right. Now, when they give those breakdowns of approval and disapproval of prior authorizations, is that going to be broken out by subject matter, or is that just a gross number that really you couldn't do anything with?
I think there's going to be future guidance issued that really provides the details on that. I don't recall at this time if that information's been provided, but.
All right. Thank you very much.
All right, any other questions? Seeing none, if anyone has any questions, we certainly could turn them in here to staff and we can continue to carry them forward to the next meeting. So with that, next on our agenda, we have a continued discussion on NCOIL Mental Health Parity Model Act. And it's in your binders on page 63 and once again on the website and the app. The sponsor of the model and chair of this committee is Representative Rachel Roberts. Unfortunately, she's not here today, but this is a model that I know she's very passionate about and looks forward to developing throughout the year. We're not going to be voting on it today, but we're still in the information gathering and comment phase and hope we have something ready for consideration by November. Great panel today, and let's get started by hearing from Jess Kirschner of the National Governors Association, and we'll hold questions till everyone is finished. So with that, Jess, go ahead, please.
Amazing. Well, thank you guys so much for having me. My name is Jess Kirchner. I'm the Senior Policy Analyst for the Children and Families team at the National Governors Association. First, on behalf of the NGA and on behalf of Governor Murphy, I want to thank you for inviting us here. As a fellow N-organization or association, I think the world is always better when we're all in contact. And the second thing I want to do before I jump into my slides is share that I am absolutely not an insurance expert. I tried this joke earlier, but you're going to get better results if you ask me for medical advice before you ask me for insurance advice. So I do want to give that caveat here. But super excited to be here. Today I'm going to talk a little bit about our 2022-2023 Chairs Initiative on youth mental health and the development of the Governor's Playbook, which was under the stewardship of New Jersey Governor Phil Murphy. Quickly, for those of you that don't know the NGA, we exist to serve the initiatives and priorities of all 55 governors in the states and territories. It is bipartisan and always has and always will be. I think we beat NCOIL by 60 years or so. We were created in 1908. And we have two primary arms. We have the Center for Best Practices, which is where I sit, which is a research and consulting organization that supports the priorities of governors through technical assistance, long-term projects, ad hoc support, peer sharing, and in-person convenings. We have 14 different policy areas, so for those of you that specialize in transportation, if I can connect you with my infrastructure team, that's totally fine. I sit on the children and families team, so we touch everything human services. Think child care, youth mental health, hunger abatement programs, economic mobility, et cetera. Which is why I'm not an insurance expert. I have a million other things to think about. And we also have our government affairs arm, which consolidates and collects the feedback from all 55 governors and works with the federal government to design solutions that meet states' needs from the top down. So we are governed in a chair structure. We have a Republican and a Democrat chair that swaps every year. So this year, our chair is Governor Spencer Cox from Utah. And our vice chair is Governor Jared Polis from Colorado. Next year, Governor Polis will be the chair of the NGA. But the reason that I am here to talk today is because each year, the chair of the NGA gets the full power of the NGA to focus on an initiative that's close to their heart. So they choose an initiative. This year, Governor Cox is Disagree Better. You might have seen it in your states, focusing on reducing political tension, divide, without reducing disagreement across parties. But last year, Governor Phil Murphy from New Jersey focused on strengthening youth mental health. So Governor Murphy, who's been a leader on this issue since the beginning of his administration, wanted to take it to a national level and involve governors from both sides of the aisle, specifically from a governor's yes and seat is what I usually call it. Oftentimes, we find that youth mental health policy, recommendations, et cetera, is viewed or presented in a silo. So this initiative was to identify solutions that worked across juvenile justice, child welfare, health and human services, and schools, and then community organizations as well. Again, taking that yes and approach that governors often have to balance. One of the goals of the initiative was that we didn't want to be too prescriptive with it. We didn't want to be too limited in the scope. We wanted to collect as many recommendations as we possibly could across a number of spaces. And the goal of the initiative was to develop a resource that was immediately useful to new administrations, something that could be dropped on the desk of a new governor and set the stage for an agenda for youth mental health in their state. And so what we did is we developed the National Governors Association Playbook for Governors on Youth Mental Health, this bad boy right here. I have plenty of copies that I will leave at a desk, and I believe it's online as well. And we focused within this playbook across 4 pillars. We have prevention and resilience, which is focusing on upstream supports and services, reducing stigma and increasing awareness of services, ensuring access and affordability of quality treatment and care. All of those words were very deliberately chosen when we designed our pillars. And then training and supporting caregivers and educators. And so across those 4 pillars, we worked to identify common pressure points, tension points, and state solutions. Because we wanted to collect, like I said, things that were actually working and actually happening in the states to help drive change in this space. So this playbook has 13 policy priorities across the 4 pillars. And across those 13 policy priorities, there are 34 opportunities. And under that, there's 100 state examples. So I know I just kind of walked you through a table of contents there, but it'll make sense when you see the document. But what we did create was basically a 50-state scan of what's working in youth mental health across states, rural, Republican, Democrat, urban, really tried to come up with a slate of solutions that worked for everybody. So to do this, we hosted a series of 4 roundtables across the country with governors from both sides of the aisle and hundreds of attendees. And we also, hosted conversations with all 55 governors at our summer and winter meetings, and leveraged the expertise of almost 100 thought leader organizations and state leaders themselves, some of which will speak after me on this panel, providing a lot more context on the insurance piece. But we've been grateful for their partnership and the partnership of several organizations in this room as well. And so to do this, the way that Governor Murphy wanted to approach it was bringing folks to the table. As a governor, and I don't have to tell you this, as elected officials, you are accountable to every constituent, business, and community organization that exists in your state. And designing solutions that work in youth mental health requires a deliberate and delicate balance that includes the voices and interests of everybody relevant to the conversation. And so what we did is we hosted these roundtables across it was a very similar setup to what is happening here today, but we had governors and state advisors, we had nonprofit and philanthropic thought leaders, we had private sector stakeholders, service providers, insurers, and consultants, we had federal agencies and youth, all of which their feedback went into the development of this playbook. And so I'm here mostly to share a little bit about that resource and offer our assistance to you. But before I close for questions, I'll share a little bit about what we learned. Governor Murphy has been a champion of parity since the beginning of his administration, but also recognized the role that private insurers play in supporting and maintaining this ecosystem of care, and the role that they play as major employers in states as well. And I think that that's a consideration that's reflected across governors. In terms of what we're seeing in movement on, we're seeing a lot of focus on Medicaid reform. I'm sure the folks after me will talk a little bit more here. Just personally, I've seen a big push in drawing down Medicaid into schools and providing those services. And one thing that's been interesting from our position is that we recognize that states where Medicaid expansion is not a topic on the table or an option or a viable or desirable solution, Some of the states that are not or have not expanded Medicaid in that way are some of the most ambitious in drawing down Medicaid into schools. And so we're seeing a big shift in the messaging and the initiatives that are happening in that space and are super excited about it. We're also seeing a shift to move upstream, as is everything these days, considering how to fund that through public and private insurance. We're seeing governors in Pennsylvania, Massachusetts, and Connecticut also thinking about how to cut through red tape that they have deemed unnecessary to the delivery of service. We're also seeing governors lean in with the power of the regulator. I know Governor Hochul in New York is really leaning into school-based services and leveraging the power of the Insurance Commission there as well. So I'll pause. I have a few more notes about state examples we're seeing, but I want to get to questions first.
I think we'll hold the questions till the end. And with that, we're gonna go to David, who's next on my list to speak. David.
Great. Well, thank you so much for the opportunity to speak with you today. And thank you especially to Chair Roberts and Vice Chair Gandolfo for their leadership. My name is David Lloyd. I'm Chief Policy Officer at Inseparable. We're a national mental health policy organization that works on a nonpartisan basis across states and federally to improve access to mental health care. And as our name suggests, we believe that mental health is inseparable from physical health and well-being. So today I will be discussing an important aspect of the draft model that Representative Roberts has put forward. And I'll be discussing essentially how we can improve mental health and addiction care by aligning providers and payers around generally accepted standards of care. And I'll discuss more about this concept as we go along. So currently, unfortunately, Inseparable believes that too often for Americans, mental health and addiction coverage, and really the system more broadly, not just insurance coverage, is failing to meet Americans' needs. We've seen a dramatic increase in needs, particularly among youth, in recent years, and this must be addressed by a wide range of stakeholders, but certainly insurance is a critical piece of the broader puzzle, given the important role that health insurance plays in financing healthcare services. So I wanted to provide just a few examples. So 1 in 5 American adults has a mental health condition in the past year, yet about more than 2/3 did not receive any treatment. And additionally, nearly 3 in 4 insured adults who received mental health treatment in the past year said they had some problems with their insurance, which frankly is too high. So we want to help address this and make sure that people can get access to the services they need. We often find in our experience and hearing from patients and families that oftentimes coverage decisions are made in a manner that frankly aren't consistent with what are generally accepted standards of mental health and addiction care. And that frequently conditions are chronic in nature and require treatment of the underlying condition. And mental health has for a long time been marginalized in our system, and we've tended to treat just kind of short-term symptoms and not actually address the underlying condition. So recent polling actually demonstrates that these issues are a widespread concern among the American public and that they support increasing access to care. In surveys, more than 90% of adults believe that there is a growing mental health crisis in the country. They also believe that expanding access to mental health care should be an important priority for elected officials, with more than 60% saying it should be a very important priority. And more than 90% of adults also say that insurance companies, should be, covering ongoing treatment for what are often chronic conditions, rather than imposing, arbitrary limits on care. And while the Federal Parity Act has addressed some of these issues, we still think that there are ways that we can improve coverage and ultimately improve health, but also reduce costs overall to the health insurance system. So I wanted to talk just briefly about aligning the alignment of standards that really protects patients, providers, and it actually protects payers by aligning around standards of care. So, we often hear that care is not medically necessary, and sometimes indeed it's not medically necessary, and people shouldn't, services shouldn't be covered that are being recommended by the provider. But here I list what are generally accepted standards of mental health and addiction care. And these, I won't read through all these, but I wanted to include them so people got a flavor of what we're talking about. That effective treatment requires, treatment of the underlying condition. Treatment of co-occurring mental health and substance use disorders, as well as with comorbid medical conditions, and doing that in a coordinated manner. People should be in the least least intensive and restrictive setting that is safe for them, but also effective. And that part is often, lost in the conversation. We don't want to put people in inpatient care who don't need to be inpatient care, but sometimes, that is necessary. There are also some other, really some common sense, standards of care that we need to consider the unique needs of children and adolescents, and that when we're making decisions on what is the most appropriate level of care for what duration, it shouldn't be based on arbitrary, predetermined, predetermined notions of how long it should be for. We shouldn't do 28 days of treatment. It should be based on the individual's needs, which again, we think is really common sense. So, mental health and addiction treatment is underutilized, and it does lead to higher physical health care costs and social costs. So McKinsey and Company has done some good research on this, and roughly 15% of the total disease burden overall is associated with mental health and substance use disorders, so mental health and addiction. Milliman has done some good research found that mental health and substance use disorder reimbursement is only, at least based on their data, only about 5% of the total. So there does seem to be a little bit of a mismatch between the disease burden and the amount we're spending on mental health. Milliman also found that between 2.8 and 6.2 times people with behavioral health conditions had 2.8 and 6.2 higher physical health care costs, yet these people, roughly half of them based on claims data, received less than $95 worth of mental health and substance use treatment a year. So what's driving the costs are the physical health care costs when we don't treat these diseases effectively. And Moody's Investor Service has found that healthcare costs for patients with these conditions are over $12,000 annually on average, but only about 8% of the spending for those individuals are for these conditions, and they recommend that in order for insurers to reduce total healthcare costs and improve their competitiveness, that they need to invest and honestly spend a little bit more on treating mental health in order to reduce the physical healthcare costs. So one way of doing this is that states have increasingly aligned providers and payers around high quality standards from nonprofit clinical specialty associations. And the example on the screen is the criteria from the American Society of Addiction Medicine, the ASAM criteria. More than half of states have some requirements now that either commercial insurance or Medicaid use the ASAM criteria for substance use disorder determinations. And if followed, it ensures patients get the appropriate treatment at the appropriate level of care for the correct duration of time. And it improves quality and really puts providers and payers on the same page to make sure that people are getting appropriate treatment and they're importantly not getting inappropriate treatment. And for mental health conditions, there's something called the Level of Care Utilization System, the LOCUS family of criteria from the American Academy of Child and Adolescent Psychiatry and the American Association of Community Psychiatry. And I should note that United Healthcare, the nation's largest insurer, has voluntarily switched to all of these criteria across all of their business and across the country in recognition that it creates a common single standard that can align and improve the quality of care. So essentially, these are elements that are contained in the draft model legislation. I put resources here that link to some of the underlying studies that I referenced. So definitely these will be available so you can link to them. But really appreciate your time and thank you for the opportunity today.
And thank you, David. And once again, that all this information is available on the website. And so with that, we are going to now go to Tim.
Okay, well, thank you very much. My name is Tim Clement. I'm the Vice President of Federal Government Affairs for Mental Health America. We're the country's oldest mental health advocacy organization. We've been around since 1909. We have affiliates in over 40 states, so most of your states have at least one of our affiliates in them. And so I'm going to be brief, and I think David covered a lot of the points about the model bill and what's in it and why that's important. I think one thing that's the most important thing to remember that we all should keep in mind is that every day in this country, over 440 people die from an overdose or a suicide. When I first started using those daily figures back in 2017, the number was 245. So it's gotten almost 200 deaths worse in the last 7 years. So we definitely have a huge mental health crisis and the opioid epidemic, which you're all aware of. So what's important when you have a crisis of that scale is that generally speaking, when you're gravely ill and at risk of dying, in our country and you have health insurance, your insurance covers the treatment you need to survive and then recover. So it's very important, that's also the case for mental health and substance use disorder care, that you have insurance coverage, you have a mental health condition, you're ill, you need treatment, you get that treatment, you survive, but also, as David mentioned, you get the ongoing treatment you need to recover and thrive. So it's a very important component of why insurance coverage for mental health and addiction in treatment is very important and critical. We're not going to solve the opioid epidemic or the mental health crisis if people can't get adequate coverage of their mental health treatment and substance use disorder treatment. And of course, that's only one piece of the puzzle. There's lots of different ways that we need to address both crises, and not to imply that it's just about insurance coverage, but insurance coverage is important. You think about it, that's how we generally pay for, if you have insurance, that's how that's the bargain we make with, you pay your premiums and you get the treatment you need when you're ill and you're at risk of dying and being disabled. Another thing that's important to note is that, when people don't get coverage, when they don't get coverage for the treatment they need through their insurance, it's incredibly expensive for states and municipalities. So for instance, it's no secret that a substantial portion of jail and prison populations have a mental health condition or substance use disorder, or often both. Now, of course, that's not to say that that's the only reason that it contributes to their incarceration, but when people can't get treatment, oftentimes through their insurance coverage, they'll get treatment through taxpayer-funded programs, or sadly, they'll end up in jail or prison, which is incredibly expensive. So making sure that people have the coverage they need, one, is important in saving lives. But two, it's very important avoiding, we have, the two largest mental health providers, mental health facilities in America go back and forth, depending on what kind of survey you look at. It's either the Cook County Jail or the Los Angeles County Jail. So that's not how we should be providing mental health treatment through jails. So instead of having people with mental health conditions ending up incarcerated, making sure that they can get the coverage they need for the treatment that they need is incredibly important for both keeping them well and also keeping them, potentially out of jail and incurring very high costs. So, and just one other thing I just want to note is, for Chair Roberts, I know one thing that's very important for her is making sure that people can get annual mental health wellness checks, sort of a checkup from the neck up. And so that's something I think is an important feature of the model, and something that a number of states have been doing on a bipartisan basis, making sure that people have a pre-deductible, no cost-sharing form of seeking an annual wellness check from a mental health provider, something that generally you can't get right now. And it's very important. It's very important to be able to, even if you don't have a diagnosed condition, to make sure you can get that checkup, to make sure that you don't have a condition, and if you do, you get routed with the appropriate treatment. So that's a very important component. It's ahead of the curve. It's upstream, as was mentioned before, making sure that you catch a potential illness before it turns into a crisis and spirals out of control. So that's a very important component of any consideration of insurance coverage for mental health conditions, is making sure that you can get that annual wellness check, which I know is so important to Chair Roberts. And so with that, I'll stop and hand it back over.
All right. We'll move now to James. You want to speak from your perspective?
Thank you, Senator. I'm James Gelfin, President and CEO of the ERISA Industry Committee. We are a trade association representing large employers on employee benefits issues. Thank you for the opportunity to participate in today's conversation. Eric has had the opportunity to review the draft NCOIL Mental Health Parity Model Act. While we support efforts to expand behavioral health access and enhance MAPIA compliance, and in fact agree with many of the points that David and Tim have made today, we do have significant concerns about the draft. Eric's member companies are dedicated to ensuring access to quality, affordable mental health and substance use disorder treatment. Since passage of federal mental health parity legislation, employers have worked tirelessly to implement parity for behavioral health services, including innovating new approaches and benefits, working to address systemic access issues, and driving quality to improve patient outcomes. This has been especially challenging because the federal agencies have defied and ignored Congress. The administration has refused to issue sufficient guidance, illustrative examples, lists of non-quantitative treatment limitations, parity analysis templates, and the like. Now, this may soon change. The federal government is expected, perhaps in the coming weeks, to finalize a new regulation that significantly changes federal parity requirements. To avoid creating disparate requirements between state and federal law, NCOIL should defer any approval of a model act until that rule is finalized and any subsequent litigation is concluded. At that time, we hope that NCOIL will ensure any model act approved is consistent with the application of federal MAPIA law, guidance, and sub-regulatory guidance. The Model Act should not go beyond the scope of MAPIA, including by establishing mandates to cover behavioral health services, because remember, parity is not a mandate, it is voluntary, although every ERIC member company voluntarily does implement parity. We hope that NCOIL will also acknowledge that systemic issues remain challenging in the behavioral health space due to factors entirely out of the control of employers or insurance plans, such as the national shortage of physicians, including psychiatrists and other behavioral health providers, and a shortage of available culturally appropriate care. Refusal of many behavioral health providers to participate in insurance networks or to accept insurance at all. Concentration of providers in specific urban areas. Significant gaps in quality, safety, and effectiveness data with respect to behavioral health providers, facilities, and treatments. And a national mental health crisis that continues to get worse even as unprecedented funds are invested in behavioral health. All of that being said, we have some specific recommendations on the language of the Model Act. For instance, the Model Act gives too much authority to the lobbying groups that represent providers. I'm sure some NCOIL members object to many of the recommendations that provider societies routinely make. For example, when the American Academy of Pediatrics recommended asking children if their parents had any guns at home, or when the American College of Obstetricians and Gynecologists recommended that OBs push COVID vaccines on pregnant women. Or perhaps some of you may take issue with the guidelines from behavioral health provider groups related to gender dysphoria or puberty blockers, or the intersection of mental health and abortion. I bet all of you on both sides of the aisle can identify examples where the guidelines put out by some of these groups are objectionable to many of your constituents. These groups should not have so much say in the definition of generally accepted standards of care, utilization review criteria, or the like. But there are other authorities with expertise that can be relied upon, so the draft should be less prescriptive in terms of defining that. The Act should tighten the definition of providers as well. While we do applaud the drafters for not including equine therapy, wilderness therapy, or retail therapy professionals, we don't think that art therapy should be included here either. The utilization management requirements are unduly burdensome. The draft requires a review of denial and appeals by a professional with the same education and experience as the provider requesting the authorization. We believe that this language would either create a provider credentialing arms race or would simply make it unfeasible for a plan to conduct responsible utilization management. As plan fiduciaries, we object to that. The draft's language on medications mirrors failed federal legislation drafted by Big Pharma. The draft bans medical management, such as prior auth, step therapy, mandates all products be on the lowest tier of a drug formulary, and disallows requirements to engage in counseling or other services. We believe this section will create a financial windfall for branded pharma companies, crushing generic and biosimilar competition in these therapeutic areas, and will jack up health insurance premiums for working families. We also oppose inclusion of civil monetary penalties for parity violations. This is a highly partisan, failed policy that was proposed as part of President Biden's Build Back Better legislation, but ultimately deemed too radical even for a bill intended to pass with only the votes of one party in Congress. Civil monetary penalties will not solve any of the problems listed above, but they will create perverse incentives for regulators and the plaintiff's bar, rather than encouraging cooperation and compliance assistance. We have numerous other recommendations related to certain minutiae, but these are our big picture recommendations in order to create a successful state-level parity regime that properly aligns with federal law. Remember that the more complicated, prescriptive, and onerous the requirements, the more it will raise costs for plans and ultimately price some small businesses and families out of coverage. So it is in the best interest of legislators, regulators, employers, plans, and patients and providers to pursue a parity framework that is reasonable, that promotes compliance over punishment, that strikes a balance between access and affordability, and drives quality, not just quantity of care. Thank you for the opportunity to share our views.
All right, panel, we have a question. Senator.
So actually, a few statements and then a question. Nowhere else in medicine has the increased focus and increased application of the medicinal treatment created such an expansion of the problem as opposed to an expansion of the solution. And I have major concerns with the lack of transparency with respect to the iatrogenic harm and the lack of psychotherapists expressing that in advance. It should be required, as with all medical treatments, that should be a mandate. The idea that it should go on ad infinitum is not evidence-based. You should definitively have a plan for what good looks like upon the first meeting and then be able to reach that. And it sounds like that's not something that you're aiming at. You want an indefinite amount of care. There's no place else in psychotherapy where, up until 10 minutes ago, where you would expect there to be a relationship between the psychotherapist and the patient, and now we're putting it into the schools where it's not only between the therapist and the patient, it's also with respect to their educator. If you want to know how to add stress to a child, to an interaction, what you do during the test is you add observation. And that stresses and creates anxiety to the person who's being observed. And now we're going to do that in our educational system where our children already can't read. So I have major issues with this particular approach. I understand and agree that there is a mental health crisis. I will agree with that. I am fundamentally disagreeing with the solutions that are being proposed at this point in time, and I would ask that you come back with some answers. And so this is where I'm asking you, do you require of your providers that they define the iatrogenic harm upon the first meeting, whether it's to the child or to the parent, or to the parent of the child, or to the patient if an adult? Do you require that they provide that and that they provide what good looks like upon the first meeting? Is that part of your evidence of care or your plan of care?
Do you mean that the provider should list any potential harms with, say,
Yes.
medications?
Absolutely.
That's part of the medical standard. That's part of the Hippocratic Oath. You're supposed to do no harm.
I've yet to find one that does. So if that's a standard, I'd certainly love to see it.
Yeah, so I think that if you're a psychiatrist prescribing medications that can have side effects or increase suicidal ideation, potentially, you have to disclose that to the patient.
Not medications, treatment, the psychological treatment itself, not the medications, the treatment itself provides iatrogenic harm to a certain number of people, and they're not informed in advance of what that looks like in order to be prepared for it and to respond to it and to tell their provider, this is causing more harm than good, can we go a different direction?
Yeah, I'm not a provider, but I would agree. I think that any harms that could potentially result should be disclosed right away up front to the parent and the child in question. And I think that without disclosing potential harms, I think that's a harm in and of itself. So I do agree that any harms should absolutely be disclosed. I don't think anyone would suggest that providers should be hiding what could be a potential harm to the child, to the parent, to the family unit. So I do think it is important that any harms are disclosed, potential harms. And yes, the idea that there should be a plan. In fact, that's a big component of a lot of insurance utilization review. You have to have a treatment plan. You have to have a roadmap for what's going to work. And if it's not working, you got to change it. So that's something called measurement-based care as well. So that's something we highly support. We don't want people just to give treatment and say, well, I hope it works. We want them to give treatment with specific goals. And then also, if those goals aren't being met, adjust and adapt the treatment.
Right, we have a
Last
couple-
question, can you speak to the problem of there not being a wall of separation where now the child has a relationship with their therapist, a relationship with their teacher who's talking to their therapist, and that's never actually happened before, and how that actually adds to the anxiety potentially of a child? What do you plan on doing to overcome that?
Well, I don't work for a provider organization, but I don't think that you should have inappropriate relationships between the parent and the therapist and withholding information from the child. But I don't think that, I do think parents do have a right to know about the treatment their child is receiving, though. I think that is important. I think it's always important that parents be kept in the loop about the treatment of their child.
I wasn't speaking to the parent and the therapist. I'm speaking to the child and the therapist. The child at school, being observed by their therapist and their teacher, and then interacting at school with the therapist. We're talking about paying schools to help provide therapy.
This Model Act doesn't address anything that's school-based.
Pardon?
The Model Act does not address school-based care. It's just about
I was-
private insurance coverage.
So Ms. Kirchner spoke to providing funding to schools in order to provide this care. So that's where I was going with this. So if I'm incorrect.
I think
then-
that might be Governor Murphy's initiative that's not related to this actual act.
Thank you.
All right, Senator Gossage?
Thank you, Mr. Chair, and thank you, Senator Thies, because it's as though you read my notes. I just want to follow up from what she said with, since we passed in most states mental parity years ago, has anyone done has any data on how much premiums have gone up because of that?
Sorry. Thank you for the question. Under the Federal Parity Act, there is, plan sponsors do have the ability to get an exemption from complying with the Parity Act if they can show that premiums increased as a result of compliance. To my knowledge, no plan sponsor has ever gotten such an exemption or applied, for such an exemption. And I think there's no evidence, to my knowledge, that mental health parity has increased costs. And I think this is in part because, as the data that I presented, suggests, that when you're actually investing, in mental health and addiction treatment, you're often decreasing other physical health care costs.
I happen to be one of the senators that doesn't like the word invest. It's because that usually means pay a lot of state dollars and a lot of taxpayer dollars. Let's invest in this or this or that. And however, here's why I'm concerned. I've been a health insurance, life insurance agent for 20 years in multiple states, nearly half the states. And I can remember when mental health parity started being added in the states. In our state, one could have chosen that as a rider. You would have paid between 15 and 20% more on your policy if you wanted to add mental health to your plan. But we now know that the expense of the premium has gone up so much due to that. And it's partially because of what was just said here. And that is, so oftentimes, the care never ends. It is, when it comes to physical therapy or any other physical health insurance plan, you must continue to show improvement. Otherwise, they will stop. Whatever the services are, I'm sorry, we can no longer do physical therapy because we cannot continue to show that you are improving. So I share the same concerns. Of course, we want folks to have mental health that need mental health, absolutely. But that has become the issue as the medications have become so expensive, the therapies have become so expensive. But what we usually see from the providers is, well, then the state should pay for it, or somebody should pay for it because these people need that. But every time we raise premiums, then you cause people not to become uninsured or not being able to insure their families, that especially on private insurance. And I agree, we have seen more and more folks now that are needing mental health. And if all of this has been helping, why are we seeing the problem grow? And in a bit, that's a bit of a rhetorical question. I know that that was already answered here, but we find that as legislators in our states that we need to invest more, but if we don't see a return on that investment, that's when the issue comes. Thank you.
Well, we definitely don't want you to invest any state dollars on this. This involves no state spending, so we don't want you to invest. We want insurance coverage. So, and just to address your point about the ongoing treatment, you're right. There shouldn't just be indefinite treatment that goes on forever. You have you see a psychologist once a week for the rest of your life. That's definitely not something we support. We don't support, the worried well getting treatment for the rest of their lives because they have ongoing just regular life issues that are coming up. We do think, as was said, that there should be clear goals for treatment, these are the outcomes you have to receive to continue getting that treatment. We don't want some blank check to providers. That's not what we want. We want accountability. We absolutely want accountability.
Okay, Representative Forrest of Benedict.
Thank you, Mr. Chairman. And I appreciate all the presenters. This is a complicated issue. I do, to respond to you, Mr. Clement, I see a therapist because I'm in the legislature, and I think we should all do that, and I will until I'm not in the legislature anymore. And I don't necessarily think that it's a terrible idea for some folks to see somebody once a week and just talk through their problems. I'm dealing with an Alzheimer's diagnosis in my family, and I always ask my therapist for silver bullets as to, to fix my problems, and he says, unfortunately, sometimes all you can do is talk about it and connect me with a support group, and that has been helpful. In some cases, mental health solutions are just being able to talk to somebody who can be helpful to you. In other cases, the mental health treatment needs to be tailored to the individual based on what they've gone through and what their body chemistry is. To Mr. Gelfan's comments, I would say, politicians love to point at times we've invested and haven't gotten that ROI that some expect. The problem being that politics is so fraught with folks who think they know about how to address issues like this, but they have no subject matter expertise. They just have talking points based on kind of what their echo chamber is. You went through a diatribe of different treatments that, based on your comments, seem like you don't necessarily believe in them. I remember you saying, for example, wilderness therapy, and I think that was a bit tongue-in-cheek, but the reality is for some folks that does help. And when we talk about investment and this sort of black and white, we put X number of dollars in and why aren't we getting these results? I think sometimes the problem is, and I know I'm saying this at a national place where we put a model legislation together, but there needs to be some flexibility. There needs to be an ability for the provider to create a plan that works specifically for that individual. We do this in education with IEPs. Why we don't look at mental health treatment the same way, I don't understand. Truly, equestrian therapy may work for some folks. We have a former president of the United States who famously seems to be doing well because of art therapy. Certainly his bank account is because he sells that art now. So my question to you and to all of the panelists is, how do we strike a balance between finding something that can be relatively easily adopted from state to state, but also provides the flexibility for providers and their patients to work together without guardrails that politicians who, like myself, who frankly do not have the subject matter knowledge outside of talking to you, the very intelligent people in this room, about how these things work. And I say that with all respect to myself and my colleagues. I think that sometimes we need to let our egos take a back seat to experts. We have politicized the hell out of mental health, especially as as a result of COVID and all that. How do we strike that balance? I mean, Ms. Kirshner, you work with governors, Republican and Democrat, and they have to strike a balance between what Democrats think. And I'm a Democrat in Oklahoma, so I know very much how it is to try to craft a message that works for my colleagues. Do you, Mr. Gelfand, believe that there is room for innovation in mental health treatment? And to all of the panelists, how do we strike that balance between bringing stuff back to our state that's relatively easy to implement and providing that balance and that flexibility for the patient and the provider to craft a plan that works for them?
Thank you for the question, Representative. I think we're largely in agreement here. So the point of those comments in my diatribe were that there may someday be data that shows that glamping in the woods is an effective treatment, or that equine therapy is an effective treatment and is valuable. That data is not there today. And it's not there today for art therapy either, even though we may have specific examples of individuals who were helped. And as such, our view is that the draft was overly prescriptive in saying this kind of provider must be covered, must be included. So what we were saying is that there should be flexibility there, rather than having the government say, this is who the plans have to pay to do this.
Thank you, and I will just quickly clarify, the NGA does not, when we talk about these policies, we endorse state flexibility and the power of the governor to determine the best pathway for their state. We recommend, we can highlight best practices based on state testimony, but we very much endorse we don't want to come up here and say that one policy is a silver bullet or anything like that. We more endorse the power of the governors to identify a pathway that works for their unique environment. I'm actually working with the Oklahoma team on a policy academy on youth mental health as well, so I understand the dynamics here. I would say, just speaking to the balance piece, is that at least the gubernatorial level, the one thing that we did learn is that there is a lot of alignment between Republicans and Democrats. It's about identifying a shared problem and similar approaches to solutions. I think the thing about this issue is that there's always going to be some burden somewhere. And so it's about bringing voices to the table to determine what is a reasonable amount of burden, financial, administrative, et cetera. And so we've seen governors do that through, like what Governor Murphy did, through task forces, commissions, et cetera, which I know can be a little bit of a well-trodden horse of like the idea of another commission, another task force, another working group. But I will say, at the gubernatorial level, we're seeing a lot of alignment on agreements of issues and differences in problems. And we found that messaging, or in solutions, the way that people approach the solutions to an issue. So I would say that messaging has been particularly resonant across our level. And so as it pertains to your work, identifying at least a shared problem to start.
David?
Yeah, thank you, Representative, for the question. I think we have to be guided by the evidence and research and ensure that is peer-reviewed, and that we're being guided, and I would agree with James, being guided by data. I think that's critical. There is a lot of data that mental health and addiction treatment does work. It is often effective. Is it always effective? No, for few healthcare conditions, is treatment always effective. So I think we have to be, insisting on good data and guided by evidence and, peer-reviewed research that really illustrates what's effective, because that will change over time. And I think the provisions in the model are really designed to capture that evolution of what is evidence-based care over time, because that will change as we learn more and more.
Yeah, I'll just follow up briefly, and my heart goes out to you. My mother died of Alzheimer's 3 years ago. It's tough. It's very tough. But yes, I think flexibility is the name of the game, and following what the research says. And in some instances, seeing a therapist every week is appropriate. Like, I have a friend in the Philadelphia area, he's in his 70s, schizophrenia, first diagnosed with schizophrenia in the 70s. He sees a therapist every week, because if he doesn't, he ends up in the hospital. And that's, of course, in addition to the medication he takes, but, that for some people, yes, that is going to be necessary, and the proof of that is if he doesn't do it, it's a worse outcome. So, but I think echoing David, we ought to follow, what the research says. Things are going to change. Maybe one day, as James said, there will be very strong therapy evidence for wilderness therapy and equine therapy. But I think that's something that we want to make sure is in place, is there is that flexibility, and there is. But following, you want to follow to make sure that we're doing what works and what we know works.
Can I follow up?
Follow up.
So,
A couple more minutes.
what's that?
We have a couple more minutes.
Okay, sorry. So my thought is, I've tried different medications for different treatments. I mean, for different things, but therapy ends up working better for me. For some folks, you're diagnosed with depression and anxiety, but it ends up being ADHD. And so these proven methods that we know are proven and have therefore been deemed, eligible to be paid for by government money for, folks who can't afford it themselves. Turns out that individual may have been misguided in going down that path. And so I guess the point of this is we have these tried and true treatments, so to speak, but now we're learning that for some folks, it's actually the wrong way, and they may have gone years down the wrong path. My father-in-law took the wrong kind of medication for a long time and is now dealing with those consequences. And it was a treatment that for someone else who had been properly diagnosed was the right treatment. On the other end of this, we have these treatments that some people consider to be ridiculous, but other people would swear by. And so I guess my question is, how do we get to acknowledging that all of the above approaches are right and getting policymakers to be willing to, and I hate to use the word invest again, but put money towards these treatments so that they can also be established as tried and true methods for some and not others. And I think, to answer my own question a little bit, I know that that's just, we need to educate ourselves, but anyone who wants to respond to that, I'd love to hear. Not everybody doesn't have to, obviously, we're running out of time.
No, I'll just respond briefly. I mean, I think you're right. Some treatments that will work for one person don't work for another, and then a treatment that doesn't work for somebody like your father-in-law, in fact, that is the right treatment for others. And I think one thing we need to be careful here is, us in the panel talking about insurance, we don't want to get too prescriptive about, we're not prescribing treatment methods, we're talking about insurance coverage, which is about treatment, of course, but I think that's something that we need to leave room for the treatment community to make sure that they, there are those best practices shared, and they learn from their mistakes. I mean, I think that's the biggest thing to do when you have behavioral health treatment is make sure we learn from what didn't work and why it didn't work and see if we can't get better in the future.
Okay, Representative Hefner.
Thank you, Mr. Chairman. Thank you, presenters, for being here today. This is, like my colleague says, it's a discussion that I'd like to look at in a different way of sort of turning it a bit in not the treatment and here it is and this is for you, but what supports do you need? And that's where we get into that individualized piece, which is definitely hard to make model law when some of these things don't work for everybody. My comment, something that I'd like to talk to and hopefully I maybe get a response to is something that I see in my world. I've been an advocate for adults and kids with disability for 20 years. And dual diagnosis in our world is intellectual developmental disability and mental health, which I don't hear, you said, with the playbook includes the voices and interests of everyone. I'd like to stop talking about disability if we could include those people that know about disability and those needs, so we cannot leave it as an afterthought, because the afterthought now is if a parent has a child with a disability and mental health, it's because you have behavior, they end up in an emergency room, which puts stress, and it also goes against ADA. What are your thoughts, if you could briefly say, about maybe some of that you do in your work to include people that have that dual diagnosis so that we don't always have to be on the outside in the emergency room putting a burden on parents, or maybe out of state because we don't treat in state? Thank you.
Yeah, I mean, I think you're speaking to a very important and overlooked fact is that individuals, particularly individuals with intellectual disabilities, have a higher prevalence of mental health conditions, and yet that's almost swept away as if, oh no, those individuals don't get mental health conditions, it's just a symptom of their intellectual disability, and that's not true. And also substance use disorder too, much higher prevalence, and that's something that is, I'll say it out loud, it is often overlooked in the mental health advocacy world, is that's part of it too. And I think you're right to bring the attention to that, because individuals with intellectual disabilities and other disabilities, developmental delays, they have mental health conditions, they can have anxiety, they can have depression. I mean, it's something that you can't ignore that and forget about it. So I thank you for bringing that up.
All right, Senator Lang.
Thank you all for your testimony this morning. As you heard from some of my colleagues, some concerns. I also share some very serious concerns with this legislation. Like Beverly, I also have my life and health license over 3 decades. I believe between the 4 people from Ohio, we probably have over 100 years of experience in the industry. I also have a very unique experience that I actually own a captive insurance company that we recently relocated from the Bahamas to the great state of Tennessee. So I thank NCOIL for picking this state. And the reason we picked Tennessee is we looked at every state that was friendly to captives, is because they were far and away the most friendly, and we were able to come here and maximize what we can do for our insureds at a greater rate than we could at any other state. My concern with this legislation is we're putting the cart in front of the horse. I believe the term I heard was the Mental Health, hang on, I wrote it down, Mental Health Parity and Addiction Equity Act at the federal government. I think we would be mistaken if we had standards more onerous or more extreme than the federal government, because keep in mind the standards we put in only affect the little guys. The large self-funded companies, they can discriminate any way they want as long as they don't discriminate in favor of the highly compensated. So my concern is we're going to be putting an undue burden on the little guys, and I saw one of the presentations, some of the folks that said this is actually going to lower the cost. I would love to see an actuary from one of the plan providers come in and provide us with that information. I believe if it would lower the cost, the plans would already be doing that. And we've all been around for a long time, and we have all been told, put this in and we're going to see costs go down in health insurance, in Medicare and Medicaid, and it's never once happened. It's never, now there may be reasons that, why that's happened that aren't germane to the plans we put in, but costs just continue to rise. So my question is, if we have a cost that the little guy has to bear, that the self-funded guys don't have to bear, we are putting those big companies at an extreme competitive advantage when it comes to recruiting. And at least in the state of Ohio right now, the number one issue with every company, every category, every sector, workforce development. And now we're going to force the small guy to pay more potentially than the big guys are paying. How do we tell the guys, hey, our regulations are more difficult than the federal government and it's going to cost you more money?
Thank you, Senator. I was going to share in a later presentation today that in a recent poll by the group Small Business Majority that represents those small guys, they found that 25% of their members are considering dropping coverage today because they already can't afford to provide the coverage based on the prices, and that's before a new Parity Act would be imposed upon them. I also agree with you that as employers, we're always told by every kind of vendor, legislator, activist, whatever it is that we want to do, in the long run it saves money, so you should definitely do it, and it never actually does save money. In this case, we don't offer mental health coverage with the intention of it saving money, right? We know that it's a cost or it's an investment that we're making. We do so because it's the right thing to do. I don't have stats on quantifying what that cost is, but I'd be happy to follow up with NCOIL staff and share some actuarial stats with you.
We'll follow up with some actuarial data, because the actuarial firm Milliman, they've done a number of studies that shows that if behavioral health coverage was increased, you would see physical costs, and that's a real actuary firm. I mean, they're a nine-figure firm, so we'll follow up with those materials as well, and James will follow up with his materials. But I do think part of the issue here, though, is we've never seen mental health treatment covered to the way it should be, so we never had the opportunity.
I appreciate that, thank you, please do. And as part of that follow-up, I'd like to know how many of the insurance providers that Milliman represents as well. That would be very helpful, thanks.
They do represent, they do parity compliance work for a lot of the insurers.
Thank you.
All right, and our last question, Representative Ferguson.
I really just have more of a comment, maybe to bring a little balance from the healthcare side to this conversation. I'm certainly for evidence-based medicine, but I do think there's still a lot of discrimination in the mental health and substance abuse space, that we don't look at it like we look at physical health, which it is a part of total health. We look at people who have high blood pressure, they're diabetic, they have high cholesterol, they have chronic conditions, and we don't expect that they're not eventually probably going to have a heart attack or a stroke, but we treat them chronically, hoping to delay that or to delay a crisis episode. I think we have to look at mental health the same way. I'm not sure that it will save money. I'm not sure that treating people for diabetes saves money in the long run. But I think we make a real mistake when we try to separate it from physical health, because it is part of mental health. And when you treat these people chronically, you're going to have to treat people with mental health and substance abuse as chronic patients. You are going to save money by keeping them out of the emergency room and from having a crisis. But I think that's a real mistake that I see a lot of people try to look at it as a separate issue than total health.
Okay, any final comments? All right, committee, thank you. There's a lot of stuff there, and there's a lot of questions yet. And I think there's going to be a lot more thought and concerns put into this Model Act as we move toward creating a model that we as a group can accept. So with that, thank you. And we are going to then move right along to discussion and consideration of a resolution reaffirming the support for the U.S. state-based system of insurance regulation in response to growing federal encroachment. And you can review that in your binders. It's page 71. And I think I'm going to turn things over to NCOL President Tom Oliverson, who's one of the sponsors of the resolution, for some brief remarks.
Thank you, Mr. Chairman, and appreciate your time and consideration. This is a pretty straightforward resolution, but very important to us and the work that we do, and very timely. If you're new to NCOIL, you probably don't know that one of the organization's primary missions is to preserve the state-based system of insurance regulation as established by the McCarran-Ferguson Act of over 70 years ago and confirmed by the Dodd-Frank Act of the early 2000s. From time to time, however, federal and international authorities attempt to encroach on the system, despite the fact that it produces the largest and most successful insurance market in the world. And that is why NCOIL always needs to be on the lookout for actions that intrude upon the state-based system of insurance. And unfortunately, we've seen a rash of those pop up in the last few years. And they are set forth in the resolution as listed on page 71 and 72 of your book. And there are frankly more that could have been listed, but in the interest of time, we put those. So this resolution, I think, a bipartisan resolution, myself along with Vice President Assemblywoman Hunter, this will be delivered to all the relevant members of our federal system, just to remind them of what federal law actually says with regards to the state-based system of insurance regulation, and that we and our friends at the NAIC are charged with maintaining and preserving and protecting that system, and that they should let us do our job. And so with that, I'll take any questions. Otherwise, I'd like to move we adopt it.
Any further questions? Any questions? And thank you for working on this along with Assemblywoman Hunter. And did you move that?
I would like to move adoption.
Okay, we have motion to adoption, second by Senator Costa. Any further discussion? Any further discussion? Seeing none, all in favor of the motion say aye.
Aye.
Opposed, no. Motion carried. That resolution is now going to be presented to the Executive Committee for final ratification on Sunday.
Thank you, Mr. Chairman. Thank you, friends. Appreciate your support.
All right. Any other business before we adjourn?